Good afternoon, everyone. Till now, we have seen how history, examination, and genetic investigations helps in managing patients in our OPD. Now we will look into the ultrasound, which is the most essential tool at our disposal. Obstetricians are only clinician which sees two lives at a time, including fetus and the mother, and ultrasound helps in managing both. Now we will discuss this session into three parts, and for the first part, we have named it as Dil To Pagal Hai, because with the advancement in the technologies of the ultrasound and new knowledge in the anatomy and physiology of fetus and mother, we are getting maddened by how much we can gain from these ultrasound. So we have named it as Dil To Pagal Hai, and it does not stop at only NTNB, it goes beyond that. So when a patient comes in the first trimester, our aim for doing ultrasound is to confirm whether she is pregnant or not, localize this pregnancy, whether it is intrauterine or extrauterine. It is the best time to date a pregnancy also, an opportunity to evaluate pelvis for other pathologies also. It does not limited to this. Subsequent visit is generally done at 11 to 13 week of gestation, which is also known as the anti-MD scan. And it goes beyond that, and further discussion will be done later on. I will be discussing the first part of this session. So initially after implantation, in the first 2 weeks of implantation, there is thickening of the endometrium and there is separation into 3 layers. By 5 weeks, a small anechoic collection which is surrounded by 2 echogenic rings, which is eccentrically placed, is usually seen by transvaginal ultrasound. We should always distinguish this true GSEC from pseudo GSEC, which is generally centrally placed and not so surrounded by echogenic rings. By 6 weeks of gestation, we can see a yolk sac and fetal pearl, and this is the time to confirm the viability of the pregnancy. When the fetus reaches 5 mm of CRL, cardiac activity can be usually seen on M mode. And if we see a cardiac activity, then we can say that this pregnancy is a viable pregnancy. This is the time to see the uterus, its myometrium and the cervix. It may show myomas which may affect the fetal growth and affect the obstetrical outcome, may affect the labor also. And it is the opportunity to see ovaries also, which may show physiological corpus luteal cyst, or there may be pathological cyst, simple cyst, or endometriomas that can also be seen at this time. Very well. How to date a pregnancy? There are 2 methods to date a pregnancy. We can use mean set bimeter, which is slightly less accurate. And we can also use crown rump length, which is more accurate measure. It is measured in the mid-sagittal section. And while measuring this crown rump length, we should remember that we should not include the yolk sac in this measurement, and limb ducts are also not included. Fetus should be in the neutral position while while measuring this crown rump length. And when reaches around 10 months gestation, it is the best time to date a pregnancy. This dating will help us in the future in cases of complications like fetal growth restriction. It will also guide us in doing some intervention which are gestational specific, and it will also help in guiding or determining the time of delivery also. It is an opportunity to assess amniosity and chorionicity in cases of higher order of gestation. Sometimes in the early scan, we see 2 embryos or 3 embryos, and in the later scan, we see one of the embryo has vanished, which could be a vanishing twin. And in some cases, a single gestational sac is seen in the first visit, and in the later scan, we can see 2 embryos, which is usually known as the appearing twin. Now, the subsequent visit is at 11 to 13 week of gestation, when the CRL has reached between 45 to 84 mm, and it is usually known as the anti-MB scan. Since last 3 decades in the Western world and 1.5 decade in India, it has become a part and parcel of our obstetrician care, at least in the urban population. NT is the measurement of the subcutaneous soft tissue behind the neck, and in this scan we also see the nasal bone. But it does not stop here. It goes beyond that. And for further discussion of this NT scan and its beyond, I would like to invite Dr. Meeta Singh for further discussion on first trimester ultrasound.
Thank you, Dr. Akanksha. So I'm sure that most of us have our own ultrasound machines at our private clinic or even in institutes. We all have been using ultrasounds. And we are very, very well versed with how to date a pregnancy, how to, first of all, whether there is pregnancy or not, or there is, or it is viable or not, where is the pregnancy? It is important to see, are there any fibroids? Because later on, if we diagnose, then as the uterus enlarges, we might miss them. Or to look at the adnexa, because as the uterus becomes an abdominal organ, it may be difficult to see them. As we have very recently diagnosed a patient who was 7th gravida with previous 6 abortions, came to us for evaluation of RSA, and then she was pregnant at the next visit, and when we did her scan, it was a bicornuate uterus. So that was never looked for. So it is very important to see all these things. And we all know when to do an NTNB scan. And definitely I would like to add that in an NTNB, if we get a ductus venosus study and a tricuspid study, it adds on to the value. And that is how it increases its sensitivity. So now what else can we do at this gestation as an obstetrician? That is what I'm going to talk about. So here there is a chance to prevent the preventable conditions or medical disorders in pregnancy and to look for certain structural malformations in the fetus, which is very easy to see if the mind knows. So coming on to this, it is preeclampsia, preterm labor, and congenital malformations. So preeclampsia, and Dr. has already discussed about it, and Dr. Sangeeta has covered a full session on it, on hypertension in pregnancy, that it affects around 11% of population, and it is associated with increased maternal and fetal morbidity and mortality. Now, what are the methods we have to screen? One is the maternal risk factor, so maternal history, mean arterial pressure, PLGF, and uterine artery flow. So there are certain maternal risk factors which we all know, if they are present, they increase the maternal risk of developing preeclampsia. Mean arterial pressure, there are certain standards by which they should be measured. That is, it should be done by an automated machine, which should be calibrated at frequent interval. It should be measured in both the hands simultaneously, and there are certain guidelines how to do it. PLGF has come in a big way now, which can be offered for screening of preeclampsia. But if PLGF is not available, or if patient is not affording, to some extent, PAPIC can help in association with other risk factors, that is maternal risk factor, mean arterial pressure. And the fourth or the fifth thing that we have in our hand is the uterine artery. So it is very simple to measure with a full bladder. When we are seeing the cervix on the sagittal plane, that is when we are keeping it at the linea alba, we are able to see the cervix. We just have to tilt it around. We have to put the color Doppler on, tilt it 20 to 30 degrees to see the uterines on one side, and you can see it at the level of the internal os. Put the power Doppler button. So put the power, I don't think there's a video, okay. So put the power Doppler button on and we can see the uterine artery. What we need to read is the PI over here. So on the left side, we take uterine artery measurements thrice, and on the right side, we take uterine artery measurements thrice. We calculate the PI and we add to it. There are centiles that are available free of cost at the website of FMF. So we can chart it or plot it over here, and we can get what is the life, whether the patient is in a high risk or low risk. And accordingly, so here we see there is PLGF also and PAPE also. So we can put the MOMS if we have either or both of them, and it will calculate the risk for us. A patient who is at high risk is to be started on low dose aspirin, we all know. As Madam had said, that PLGF is more important than PAPE, but however, if it is not available, this was a screenshot I took from the lecture of Professor Kipros in 2019, Fetal Medicine Foundation conference, and he said that if we rely only on the history, we'll be able to detect about 50% cases. If we add uterine artery PI, we'll be able to detect around 75% cases. If we add mean arterial pressure to it, we'll be able to detect 90% of the cases. This will go on to 95% if we add PAPE, which is a part of our double marker test. And if we add PLGF also, it goes to as high as 97% risk for a 10% false positive rate. So this is what we can do sitting in our own clinics. And if it is high risk, then the patient can be started on low dose aspirin from 12 weeks to 36 weeks of gestation. Some societies say that it can be continued even till delivery. Now, the second case is of preterm labor. When a patient comes to us in first trimester, and if we are doing her ultrasound at 11 to 13 weeks, we can always look at the length of the cervix. If it is more than 3 centimeters, we are fine. We don't have to do anything. But if it is looking at less than 3 centimeters, we can go ahead and do a transvaginal ultrasound to measure the cervix. So should it be done in all the patients? No. There are certain guidelines. It is said that a patient it is proven that a patient who doesn't have any preterm birth has a very low risk of preterm, that is 4.4%. But with every preterm, it increases. And even a patient who had previous twin pregnancy is at high risk of developing a preterm in subsequent pregnancy. So a patient who has a previous normal delivery, she can be assessed for cervical length at the time of TIFA. But a patient who had a previous pregnancy, which ended up in a preterm birth, somewhere between 14 to 27 weeks of gestation, should have a transvaginal ultrasound measurement of cervical length at 14-week gestation. So these are the patients who, when come to us in the first trimester, should have a transvaginal ultrasound done to measure the cervical length. And depending on the length, further measurement should be done. Third thing is structural malformation. So there are certain structural malformations which are very difficult to diagnose, but there are certain which are very easy to diagnose. If we start doing our scans at around 11 to 12 weeks, it is very easy to see this type of biparietal diameter. Yes or no? Yes. So if we are seeing a fetus like this, or if we are seeing a head like this, a slight deviation can be identified. For example, if we are not able to see the parts in between, both the lateral ventricles have continued to be together, we are dealing with a case of holoprosencephaly. That can be seen by us. If we are seeing lot of fluid around the nape of the neck, if we are seeing a baby in sagittal, this is hydrops, or if there are septations, this is cystic hygroma. We don't need a fetal medicine specialist for this. We can do it on our own. Similarly, if we are seeing a CRL, in the plane of CRL, a large cystic swelling, we are dealing most probably with megacystis, which can be easily diagnosed. Or if we are not able to see the calcified calvarium at the head, or in this plane, we are dealing with acrania, which progresses to anencephaly. We are still seeing cases of anencephaly coming to us in third trimester, which can be very easily picked in first trimester. So there is a whole list that is present where in first trimester, we should not be missing. And in our practice, specifically the anomalies in the brain skull, that is anencephaly, holoprosencephaly, large encephalocele, or cystic hygroma, or that are present in the abdomen, like large omphalocele or gastrochisis, limb body wall complex, where we are not able to see the whole anatomy, or megacystis can be detected. It is easy, or it is okay to miss all of them, but these cases can be missed at our own clinic. Thank you so much. So this was about the structural malformations. So beyond MTNB scan, what we can do, 3 things: preeclampsia screening, preterm screening, and certain congenital malformations that can be done by us. That's all. Thank you. So now I invite Dr. Soni for our second scenario.
Thank you, ma'am. Good afternoon, everyone. I'm here to present the S2 of ultrasound. My first case is this is a role of ultrasound in detection of multi-gestation pregnancy. My first case is Mrs. A, 26 years old, Gravida 3. Previous to spontaneous abortions, she conceived spontaneously in this pregnancy. Came to our department with 3 months of amenorrhea for booking. Outside USC, which was done at 7 weeks of gestation, was suggestive of intrauterine gestation cycle of 6 weeks, 5 days. Detailed history and clinical evaluation was done. Ultrasound done our department was suggestive of bichorionic diabetic pregnancy with twin with CRL 10 weeks, 5 days, twin B with CRL 10 weeks, 2 days. Cardiac activity was seen in both fetuses with single placenta with lambda sign. As we can see, this is showing lambda sign, which is thickened chorionic tissue with the amniotic membranes on the side. This patient followed up in pregnancy and she delivered the babies, and they both are doing well. Learning point from this case is twin pregnancy will be missed on early ultrasounds. Sensitivity of the sensitivity of transvaginal ultrasound is more than transabdominal at early gestation and detection of multiple pregnancies. Then the next case is Mrs. B, 30 years old, gravida 2, previous one liver issue, conceived spontaneously, referred to MRH in view of pregnancy. Ultrasound was done, but transvaginal ultrasound done. It was suggestive of monocorionic diabetic pregnancy. Learning from this case, chorionicity can be best detected by transvaginal ultrasound at early gestations. We can to differentiate chorionicity, we can use the lambda sign and the T sign. And the sensitivity of this lambda sign and T sign at 9 to 14 weeks is having 100% sensitivity. At 13 to 20 weeks, it's 85 to 90%. At about 20 weeks, it's sensitivity. This is a video showing twin gestation without any intertwin member. It suggests monogamic pregnancy. Then the next case, Mrs. Z, 35 years old, primary gravida, IVF conceived, bichorionic diabetic pregnancy, was detected to have increased LT in 1 period at 12 weeks, 6 days gestation. Came with amniocentesis report to our department. The report was suggestive of fetus with normal knuckle translucency was affected with trisomy 21, and the other with the normal abnormal knuckle translucency was found to be having a normal karyotype. This is the twin that having increased LT and the nasal bone ossified, and the amniocentesis report which was done outside was suggestive of normal karyotype. This is a twin B, 12 6 days, MT was normal, nasal bone was seen, and the report was karyotype was suggestive of trisomy 21. The couple wanted selective fetal reduction. There was confusion with which fetus to select for reduction. Couple counseled regarding same, and they were willing for the repeat amniocentesis. Detailed ultrasound with proper labeling of the twins done. As twin on maternal left and maternal right. Amniocentesis was done at 17 weeks of gestation. Twin on maternal right, fish 21 was normal for the twin having normal knuckle translucency. Second one on maternal left, the fish 21, in which the knuckle translucency was increased, the twin was affected having trisomy 21. learning point from this case teaches us that why the labeling of the twin is important. Not only for the purpose of selective fetal reduction, but also for the management of subsequent growth of fetuses and predicting their outcome. It should be noted that the lower fetus should be labeled as twin A. The higher order pregnancies which we see in routine quadruplet pregnancy and quadruplet pregnancy. Then the next case is Mrs. P. Private Lavia, 36 years old, highly conceived, referred to our department in quadruplet pregnancy. For intrauterine gestation was seen and the cardiac activity was present in all of them. Ultrasound done at our department was suggestive of tetrachorionic anaerobic pregnancy. The patient planned for multi-fetal pregnancy reduction. Detailed counseling with the patient when the relatives was done and multi-fetal pregnancy reduction done. Patient withstood the procedure well. There were no post-procedure complications, and she was followed up throughout the pregnancy. This is the this is the slide showing the procedure with the inside the cardiac, and the KCL was given and cardiac activity stopped. The patient was followed throughout the pregnancy and she delivered two healthy babies. And this is the picture of the reduced fetus. And what we learned from this case, option of fetal reduction should be discussed with the couple, should be done after 11 to 12 weeks of gestation. Transabdominal approach should be preferred. Now I would call Dr. Neeta ma'am for further discussion. Thank you.
Thank you, Dr. Soni. So one message, most important message from this series that we have taken out is that once we know that what is the twin, whether it is that there is a twin and it's a dichorionic twin or a monochorionic twin, labeling is very important, because as she showed in one of the cases that the fetus which was having a high NT was given a report of having a normal karyotype, and the normal one was given of abnormal karyotype of trisomy 21. So it was very, very difficult to tell them and explain them, being in our ethical limits, and to persuade her to go for a repeat amniocentesis, taking up all the risk again in an IVF conceived pregnancy. So dating is very important in twins. Apart from this, in twin pregnancy, so why we have to do a multi-fetal pregnancy reduction? Because we all know that higher order pregnancies are at high risk of maternal and fetal morbidity. So definitely when we are doing an ART, this bill wants more. It wants, if we are going for this, let us have a twin pregnancy, and we want that mother and the baby, all of them should be fine at the end of the pregnancy. So apart from doing identification of the twin, the chorionicity, dating, labeling, and to look for congenital malformations. Also, so there are some challenges which still are unattended in this, and they are: one is aneuploidy screening. Though the guidelines are now in place and we know how to go about them, so there is either a so what we need to understand is, in a dichorionic pregnancy, there are two fetuses and two placenta in one mother, and in monochorionic, there are two fetuses and one placenta. So in a dichorionic twin pregnancy, when we take one blood sample, the value of the biomarkers that come are from both the placenta. So we get it in moms. Now let us say the value of these moms is X. Then what the lab does is that when we do a NT-NV scan for these twins, it adds the value of NT of first twin to the value of the biomarkers in the mom, and it gives us a certain risk value, which is the risk value for the first twin. And it adds the NT to the X mom value, and it gives another risk value for the other twin. So here, after the pre-test, so the parent should be counseled adequately that for these two fetuses, we are going to may get two different values. And here we need to sample the twin which has got a high risk. But in a monochorionic twin, the NT is averaged and that is added to the mom value of the biochemical markers. And what we get is an average risk, which is the risk for both the twins. Now here, if the risk is low, we follow. But if the risk is high, the dilemma is whether one twin should be sampled or both should be sampled, because in some instances, they may be discordant genetically. So the call is up to the patient. For all practical purposes, in monochorionic twin, if we sample one, it is the same. But sometimes patient may ask for both and it can be done. Now, Dr. Soni showed us a case of fetal reduction in higher order pregnancies. So usually fetal reduction is done in those conditions where there are triplets, quadruplets, or pentaplets. But in certain conditions where we think that the mother is already a high risk for certain maternal diseases like chronic hypertension, or we get a lot of patients who are renal transplant recipient, or when the mother is having a spinal deformity, there we may consider, or in case of Takayasu's arthritis, as we reduce twins to singleton, where we don't want the mother to carry the burden of twins also. Or in certain conditions, we may have to do selective reduction. How is it different is we identify which fetus is to be reduced. So they are the fetuses who are either malformed or in certain conditions in monochorionic twin pregnancy, where there is a vascular connection between both the twins. And if one twin dies, we know that the other twin will also suffer. So we may have to clamp or stop the vascular connection by either RFA or fetoscopic cord coagulation and convert it into a singleton. So I'll not go into the details, but what we need to know in monochorionic is there is one entity which is selective fetal growth restriction, where because though they are genetically similar, so they have the same growth potential, but since there is unequal placental sharing, this fetus is very small. And apart from growth discordancy, there are Doppler changes. It is important to look at the Dopplers for a long period of time in this twin. If the Doppler is high, it is managed like a singleton twin. If there is ADF, depending on the timing, if we think that they are mature and this baby can die, we deliver. But the problem that is most commonly encountered is type 3, which is this twin, in which at some point of time we are having a normal value, but at some other point, this twin is showing ADF or reversal. So this is type 3 SFGR, and they are at very high risk of sudden fetal death. And if there is a sudden fetal death in monochorionic twin, we know that the other twin can also suffer from sudden and acute hypotension. So they should be managed very carefully. So I would like to end this and call upon Dr. Shilpa with the Divana Dil because of her beauty. Good afternoon, everyone. Here, Dil Divana Dil Saja Ke Manena. So our FGR, that is ST of ultrasound Doppler in fetal growth restriction. So FGR examination, that is management of FGR, is incomplete without Doppler studies. So we will see our bill, and for us, this is our Doppler, which is bin sajna. Without umbilical and MCA studies, our FGR cases will not be managed properly, and here are the cases depicting the same. So let's say Mrs. X, primary gravida, spontaneously conceived, referred us at 15 weeks of POG with comparing test suggestive of risk for trisomy 21 more than 1:50, mentioning PAPA level being less than 0.4 mmol. So with no significant past history and family history, clinical examination were normal. So in ultrasound at our side, no gross malformation at 16 weeks were noted. Amniocentesis was done, and as we have discussed, microarray karyotype was set, and that was normal.
PIFA at 20 weeks was suggestive of no congenital malformation and hence referred back to treating obstetrician for further antenatal care. So the patient again came to us at 28 weeks with USG suggestive of oligohydramnios. So we looked at her graph, which was done at our side, and that was 16 weeks, 20 weeks, and at the 30 weeks. So patient at 28 weeks was suggestive of estimated fetal weight at 4.7%, less than 10 centile, and abdominal circumference that is at first centile, that is less than third centile. So that is suggestive of fetal growth restriction, early onset. So we have done we have gone ahead for umbilical Doppler that was suggestive of raised umbilical artery PI with normal middle cerebral artery Doppler. Hence, again further we have done ductus venosus flow, and it was suggestive of normal studies. We also noted that there is ongoing worsening, that is decreasing Riker was seen and noted, and his patient was at 28 weeks diagnosed to have early onset FGR with most likely cause being uteroplacental insufficiency. Patient again counseled further for the multidisciplinary team regarding fetal condition, management plan, risk of preterm delivery, social and financial arrangement for the same, and asked for closed follow-up. And hence, at 29 weeks, patient reported to us with an ultrasound studies were done, suggestive of absent end diastolic flow in umbilical artery, increased flow in middle cerebral artery, and hence the ductus venosus flow seen normal with progressive worsening oligohydramnios, AFI less than 4 centimeters. Hence, further patient counsel for admission, and patient got admitted. Steroid coverage was done. Patient was asked to keep DD fetal movement count. Biophysical profile was done to look for fetal status and also daily Doppler. So in the ward at 30 weeks of 4 days gestational age, we have Doppler intermittent reversal of end-diastolic flow in umbilical artery, reversal of A-wave ductus venosus flow. So patient was taken for elective LSCS with fetal neuroprotection, magnesium sulfate dose, and antibiotic 4 hours prior. She delivered a male child with 957 gram, Apgar being 7 and 8, required CPAP support for 3 days. Kangaroo mother care was given. As a complication of preterm delivery, neonatal MEC has episode of MEC has happened on day 5 of life, but baby survived and discharged on day 40 of life with weight being 1.5 kg. So learning lesson in this case is close follow-up for fetal growth restriction needs to be done. Doppler is helpful in timing of delivery. This also emphasizes on low pattern level being a risk factor for FGR and multidisciplinary counseling. So going on to case 2. So let's say Mrs. G, gravida 2 para 0010 with spontaneous conception came to OPD at 9 weeks for booking visit with normal antenatal course, diagnosed as IHCP at 32 weeks, serum bile acid at 23 per ml, responded to ursodeoxycholic acid at 300 mg TDS. We see at the graph of this patient, so we see fetal weight, estimated fetal weight at 14.5%, but the growth is static, with AC being less than being at 4.7% and AC being also static. So we go ahead and done a Doppler ultrasound, umbilical artery Doppler with
calculator and we have put the percentile. So percentile index being 1.1 and 72% being normal. But when we did an middle cerebral artery Doppler, we have found out that percentile index is 1.15 being pathological at 4th percentile. So, if we put that in a calculator, our CPR calculated as 1.045 being at first percentile and being pathological. Patient was, induction of labor was done for the same patient and preterm vaginal delivery was monitored thoroughly. She delivered a female child of 2.6 kg, Abgar being 7 and 8. Baby cried immediately after birth, discharged on day 6 of life. So, this was our baby and mother. So, learning lesson from this case being FGR can be late onset. So, graph has to be plotted for the same and fall in sentence of growth chart should be noted. So, umbilical artery may be normal, but middle cerebral artery Doppler is mandatory. If this would not have been done, the result would have been different in this case. So, I will call upon Dr. Neeta ma'am for further discussion. And
Thank you. So I think this is how what we do. We sit with the fetus, we look at the Doppler, and then we decide, and when we save a baby, we clap for ourselves. So this is how we cannot thank our Dopplers enough. And as we see that not all growth restricted babies are actually fetal growth restriction. Some of them may be constitutionally small. So when we have a look at their parents and we think that, yes, both of them are small, or all her children were small, or she was small and they were all mentally normal, and the baby has been following its growth chart, which is very important. Nowadays, the machines that we have, we can go back and enter the centiles or the measurements of the ultrasound that might have been done outside, and we take out the growth chart of that particular baby if it is coming out to be growth restricted. So if it has followed a particular growth chart, that is probably a baby which is constitutionally small, or SGA. There can be extrinsic causes like maternal poor weight gain, anemia, or there can be a primary fetal defect. That is not the cause of concern here. The cause is that if there is a utero-placental insufficiency, which is actually fetal growth restriction. So here we need to take into account our Doppler, because once 60% of the placenta is obliterated, the Doppler will be abnormal. So we totally rely on the radiologist to tell us, but they will not tell us what to do. We need to know what to do. They will give us the report. So actually what happens physiologically is that once there is a decrease in the umbilical venous volume and liver size, because baby has a poor reserve, once there is uteroplacental insufficiency, decrease in the nutrients, the baby will start utilizing the nutrients from the liver. So the first thing that will become small will be abdominal circumference. That what we call as asymmetrical FGR. So the AC starts lagging. Once 60% of the placenta is obliterated, there will be increased umbilical artery Doppler resistance. So once this goes on, the baby then starts to save its 3 vital organs: brain, heart, and kidneys. So there is a redistribution of blood flow from the intestine and the legs towards the brain, what we call as a brain sparing effect. And that is why we measure the middle cerebral artery. But along with that, there is, it is brain, heart, and the adrenals, not the kidneys. So the blood supply to the kidney decreases, there is decreased urine output, and what we see as oligohydramnios. With further insult, there is absent end-diastolic flow in the umbilical arteries. Then most of the mothers will start complaining of decreased fetal movement. It may be associated with poor variability on CTG. There is reversal of end-diastolic flow, then absence of A-wave in ductus venosus, the biophysical worsens, and NST becomes poor, finally leading to fetal death if not attended on time. So if we look here, This is the crux of the whole presentation of FGR. Once there is fetal growth restriction because of uteroplacental insufficiency, there is this placental disease that is occurring continuously. From the placental disease, once 60% of the placenta is obliterated, what we see is increased resistance in the umbilical arteries. Then there is a stage of compensated hypoxia, that is, baby is becoming hypoxic because of decreased blood supply, but it is trying to compensate by redistribution into the brain, heart, and the adrenals. So at this time, we see increased flow in the brain. Normally, the cerebral flow is a high resistance flow, but there is more amount of blood that is being pushed into the brain. So we get more amount of diastolic flow in the middle cerebral artery. And when we compare the pulsatility index of umbilical artery and the middle cerebral, in normal patients, pulsatility index of middle cerebral is more because it is very high resistance. So there is a pulsatile flow. And that in the umbilical is less because we want blood to flow. So it is not very pulsatile. But this becomes reversed and what is called as centralization. Once it further worsens and there is decompensated hypoxia, it can manifest as absent or reversal of end-diastolic flow or increased velocities in ductus venosus. So ductus is something that is supplying to the heart. So here the heart muscles also undergo cardiac ischemia and there is diastolic failure, which is the fourth stage. And if further not attended, there is a reversal. So that can lead to systolic cardiac failure or severe or serious injury to the baby. So likewise, it has been categorized also nowadays into stage 1, 2, 3, 4, and 5. Whereas in case of late onset FGR, that is more than 34 weeks, the only difference is that since the insult occurs so rapidly, there is very poor time of compensation, and usually we get umbilical artery abnormal in decompensated hypoxia. And that is the time where there can be an unexplained fetal death or stillbirth. How to manage these patients? This is a flow chart which you can take a picture. So if it is the baby is in stage 1, then we can safely deliver them at 37 weeks. But if it is an absent end diastolic flow or there is a reversal of flow in the aortic isthmus, then we need to deliver them by 34 weeks, not beyond that. If there is pulsatility index in ductus is high or there is reversal of end diastolic flow, deliver them by 30 weeks, not beyond that. Whereas if the ductus venosus is absent or reversed, though it is said that you can deliver, but here we need to look into our NICU setup. What is the viability and whether that baby can really be salvaged? And a word about Ecosprin, as ma'am has pointed out earlier, that this is a consensus that has come up very recently, which says that if you look at point number 7, there is still insufficient data to recommend routine treatment with aspirin in all women with high risk of FGR. However, in the women who are considered to be may be considered in selected cases, such as women at high risk of preeclampsia or those with a history of placenta-mediated FGR. In those cases, we can give low-dose aspirin. Thank you.